Hi, everyone. Good afternoon. I'm Lindsay Goldfarb, Healthcare Education Program Manager, and on behalf of the Massachusetts Health and Hospital Association, welcome to today's webinar, Analytics for the C-Suite. A few logistics before we begin. We'll be recording this session for those who aren't able to join us, and all lines will be in listen-only mode. If you have any questions during the webinar, please enter them into the chat box. The questions will come directly to us, and we'll do our best to address as many as we can during our time today. Following the webinar, we'll be sending out a brief survey as well as the webinar recording. I'd like to take a moment to thank MHA's 2021 sponsors for their support in underwriting today's webinar, which is part of a series we're doing to bring experts to our members to help address timely issues relating to the COVID-19 pandemic and other hot topics in healthcare. In particular, I'd like to thank our session sponsor, Dimensional Insight, a longtime supporter of MHA. And I am also pleased to introduce our moderator for today's webinar, Kathy Csuite, Vice President of Marketing at Dimensional Insight, who will lead our session for the day. Over to you, Kathy.
Thanks, Lindsay. As we all know, analytics has become a critical driver in the everyday success of healthcare operations. During today's webinar, you will hear from top thought leaders on how they are using analytics for everyday decision-making. During the discussion, you'll hear from C-suite experts on how they incorporate analytics into their strategic approach on leadership, improving patient care, informed decision-making, and ensuring financial success for their organizations. Now, I'm pleased to introduce our speakers today. Dr. David W. Bates is Medical Director of Clinical and Quality Analysis, Information Systems at Mass General Brigham, and Chief in the Division of General Internal Medicine at Brigham and Women's Hospital. Nora Lissy is Director at Dimensional Insight, an analytics software company based in Burlington. And Dr. Frank Powers is Chief Medical Officer at UMass Memorial Health, Harrington Hospital. We're delighted to have you all here today. So let's dive right in. My first question is for all of you. I'm interested in what are the primary ways that you use analytics in your day-to-day decision-making? And David, let's start with you for this question.
We use analytics in a whole array of ways, from things like making decisions about staffing to figuring out which parts of our institution are most full or have space, and then also we try and make predictions about where things are going, for example, in terms of census.
Great, thank you. And Frank, how about you? What are the ways that your organization is using analytics every day?
Yeah, sure. To build on what Dr. Bates was saying, these days we're just swimming in an enormous amount of data in the US healthcare system. So a statistic, I'm a bit of a numbers nerd with an engineering background, but one statistic I saw this in 2020, we created 2,300 exabytes of data, which 1 exabyte is a billion bytes, which would be, if you had a phone plan that had that much data in it, it would take 240,000 years or back to the dawn of Homo sapiens to use up your time on a video call. But that being said, there's so much data out there, it'd be hard to avoid using it in a day-to-day basis. But I think the key is to use it, in an intelligent and efficient way. And of course, from a clinical standpoint, I'm a hospitalist by training. It's kind of knee-jerk for physicians to use the data for clinical decision-making, both for making decisions on testing and therapy, need for hospitalization, appropriateness for discharge. These days, we're using it more and more for population health management and changing that old model of waiting for the patient to come to you and then discussing what you're going to do. And rather than now we're through data analysis, reaching out to the patients and saying, Liz, it looks like you're due for this, that, and the other tests with regard to colorectal and other cancer screening. We use it for preventive care in other realms, chronic disease management, immunizations, well child visits, as Dr. Bates mentioned, to assess staffing needs. It can be used to assess provider performance, both from a productivity standpoint to assess your manpower needs for providers and other staff, and to evaluate things from a quality perspective. Otherwise, of course, it can be used for our end users to assess patient engagement and satisfaction. And we're all, of course, aware of this, a lot of the tools from some providers out there, such as Press Ganey. So it can be used in so many ways.
Now, Nora, in your role, you work with healthcare leaders in using analytics. What are the main ways that you see them using it in their day-to-day decision making?
Well, exactly what both doctors have said. It's a myriad of ways to do it depending on the departments that you work with. A large number of them, like for instance, we have a couple of hospitals down in Puerto Rico, one that has 13 ERs, and trying to manage across those ERs and see how their volumes are going and sharing patients across the organization is one of the big things that they do. They have their CEO has it on his iPhone, so that every morning when he wakes up, he can see, what are we looking like, and do we have enough? So it's very important to them to, as far as from a CEO suite, they want to see, what my experience is, it's more of show me the picture so I can see the colors. If it's red, I have someone to call. And then it really trickles down to the operational people and what they can do with that data, in such as, to the point of, predicting your staffing, having the ED look at their volumes and say, okay, we've, in some of my cases, we've built predictors where they know that if my average length of stay in the ED now is running about 300 minutes, then I need to open up this many more beds to accommodate the typical flow that comes in. So we use it from an operational standpoint, also from a post standpoint, if you will, on post-discharge, how do we do? What can we do to make things better? So on and so forth. Developing work queues for office staff to know we need to call these patients to come in for their visits, those kind of things. So it is all across the board in different ways.
Great, thank you. Now, my next question is, how did the COVID-19 pandemic impact your use of data? And Frank, I'll start with you for this one.
Oh, sure. Gosh, I mean, COVID-19 was just such an unprecedented and hyper dynamic situation. It created the need to track whole new sets of data that we didn't even think about collecting before, and data that was involved in helping predict its spread across the world in various regions, monitored by such organizations as the Institute for Health Metrics Evaluation and the Johns Hopkins Group, down to local and regional calls to assess bed capacity. We were all on these calls with DPH at the height of the various surges on daily, sometimes twice daily basis, to help balance load across not only systems but regions in a way that hadn't been done before. Requiring cooperation amongst competitors was a fascinating test case. It's been used to, we're using to track demand for testing and positivity rates, and using that information to help predict where we were and what the bed needs would be and what other needs would be. The evaluation of the tests themselves, there are various tests out there. They have differing sensitivities and specificities and turnaround times, and using that information to, which will also affect, the amount of PPE you're using. And the supply chain was hit in such a dramatic way that those were really big, important decisions. There were some hospital systems that people were wearing trash bags, and so that drove some of the decision making, down to evaluation of potential therapies. And it's been such a dynamic situation that it almost seems like ancient history to look back at how we were looking at hydroxychloroquine and convalescent plasma, and those are just passe now. You wouldn't even really think about using them, but up to other therapies like monoclonal antibody therapy and amongst others, and then up to the vaccines. There are various vaccines available, a few available in the United States, others available throughout the world, looking at their efficacy and their side effects, monitoring supply and demand. Who can forget, looking back to the early days of the vaccine availability, just the feverish demand there was. And even we did this kind of nifty thing, looking at the data from various national polls for vaccine acceptance, census data just in our state in Massachusetts, as well as data produced by DPH on the mass.gov dashboard, which was amazing and still is. And with all of that, we were able to predict within a week or two when our demand was going to fall off a cliff. And we went from doing, we're a small system, and we were doing over 700 shots a day, and we could predict, by, it was about mid-May or so, the demand just plummeted. It kind of petered out with people coming in for their second shots, but by July, we were giving 1% of the number of vaccines we had been early on. And now we're using some of that same data to help predict what we might need to do when the vaccine is approved for children or for a booster dose to a wider audience other than just the extremely immunocompromised. And again, it's been so dynamic, we can't even predict what we'll be doing next week, to be honest. Thank you.
That's interesting. Nora, how did you see the pandemic impact organizations' use of data?
Well, the first thing is, one thing that you have to remember, hospitals are resilient. They'll get hit with storms, they'll get hit with infections and overflows. And they got into the resiliency mode, and they developed Excel worksheets, paper, that when you're in the height of the storm, you're in triage, you got to put a sticky on your pants and keep on going. And then as we began to really get deep into the pandemic and realizing that they're shutting down, there's no longer ambulatory visits and so on and so forth. I helped several organizations, one really big organization in South Florida. We did a huge project with them to be able to understand where what was their volume pre-pandemic? What are they doing now? Are they able to shift to virtual visits so that they can maintain some of that volume, but also and take care of their patients as they had. So there was a lot of variety in that way. So we looked at, what are we coming out of the pandemic? And then of course you get the second surge, and how do you get that? So it really was, first off, I was amazed at how quickly organizations really, we ran to try and help them out, and they're like, no, we got what's going on right now on the ground because we have to have our heads in there. It's really help us figure out after the dust settles, what do we got to collect to make sure we can handle this again the next time even quicker and have the information we need, such as what Frank had talked about with supply chain. Where do we go with supplies? Where are we in surgeries? How do you go about rescheduling the surgeries that you had to cancel, but also maintain the schedules of people that already had pre-scheduled schedules? So it really brings in a lot, as he says, it's very dynamic and a lot of different factors you've got to consider. And we've gone about a couple of different ways.
Thanks. And David, how do you think the pandemic changed your use of data?
Well, as both Frank and Nora have described, it just changed things in a whole array of ways. First of all, we just wanted to have a really accurate count of patients of every type and to know where they were and how sick they were. We had a lot of work to do in terms of projecting our needs for specific types of equipment, and we were terrified of running out of many of the key things, especially early on. The whole telemedicine thing was maybe clinically one of the biggest changes, because we went from overnight seeing almost no patients through telemedicine to seeing essentially all our outpatients through telemedicine. And initially our systems to support that kind of broke down and couldn't handle the stress, although that got better. We did a lot of modeling about what the census would be like, because we wanted to, when we were on the way up, we wanted to know, like, how high is the peak? When might this be over? And then another thing that we put in place was a big central repository to enable research and answer a lot of questions about this illness in ways that were much more rapid than we would have been able to do in the past. And we're able to enroll a huge number of patients in trials and then get data about whether some of the therapies that Frank was talking about worked or didn't in a way that was much more rapid than we're really used to.
Thank you. My next question, where do you think improvements could be made in how your team or Nora in how hospitals use data? And Nora, I'll start with you for this question.
Well, I really do believe that one of the things that came out of COVID is the realization that you need data and you need to make decisions using data. Where I still see those sometimes is it still is, if you go to the finance world, they're all about data and they have all the data they want. It's really getting to the operational people and helping them get the data that they need to do their operation on a daily basis without having to jump through too many hoops. And so I feel like the analytics piece of it needs to get out to like your quality and your performance and your operational people, so that will help guide them, kind of like what we put together for COVID, where you're following your census and you're doing those things. They were put together to help through this surge, but they're actually pieces of data that could be useful throughout the rest, whether there's a pandemic or not, to help understand operations and how to smooth things over.
David, what do you think? Where do you see improvements that could be made?
My answer is very much the same as what Nora just described. The key thing really is to get access to frontline managers for the data that they need. That includes the views that they need, because often the views are not readily accessible, and it also includes visualizations. I mean, we've seen an incredible number of cool new visualizations to help you interpret the data during COVID. That's the kind of thing that we just have not had historically. But I think going forward, that's where we want to go.
And Frank, what do you think about this question?
Yeah, sure. I mean, to build on what David and Nora said, a lot of this has to do with all of your staff really being able to develop an appreciation for what the data means. And first of all, you're not going to know what something is until you decide to measure it. And you have to figure out what you want to do. You have to collect data. I think that you have to have the ability also to assess the quality of the data. You know, to get back to the early days of the COVID pandemic, when DPH was really scrambling to collect as much as possible, you could see these huge discrepancies, because all of the spreadsheets and such were publicly available. And some of it just didn't make sense, and it didn't even match to, it was just depending on who you asked, even within an organization, you get wildly different numbers because people were interpreting the questions wrong, or different, I shouldn't say wrong, differently, and you'd have, a question of like, how many beds available you have? And someone would, from MGH would answer like, we got 2, which means like, that's how many empty beds. And someone from some little hospital said, we have 100. And of course, there's a disparity there. So when you're using that data to make decisions, you have to have some confidence in its quality. And to get to what David was saying, I think it's super important that you educate the people that you're working with on what your goals are with the data, and you listen to their feedback of how they're going to use it. As a physician, I think it's super important that because so much of this is used in clinical decision making and population health management, and there's a lot of burden on the physicians and other providers to be collecting data. And maybe I think there's a lot of room for improvement in offloading some of that to, I don't think you need to go to med school to collect some of the data that we're asking for. And maybe even giving some of that directly to patients to collect. It's for their benefit without burdening them either. The other part of this too, I think it's important, particularly on the clinical side, but in every aspect, is having the discipline to move away from some types of data collection. I think one of the things that I see is that we just say, hey, we're measuring, this one thing, and everyone's excited about it, and the CEO's asking about it, and then the flavor of the month comes, and we're going to measure this, but we never get rid of the stuff on the bottom that no one's really dealing with. But some course the slob is having to enter, and it's death by a million clicks, and all of this is a precursor to just fanning the flames of the pace of burnout. So if we could get rid of some stuff, I think I'll never forget, I participated in a seminar with the Meditech folks a few years back, and they have like a whole team. It's their click reduction team, and I got to be honest, we're a Meditech shop at the moment. And despite that, they still got some work to do because there's a lot of clicking going on, and that is just the bane of a lot of providers' existence. And there's a reason. I have to say, it's not just about the clicks, but that's just one of the things that is a challenge for the primary care people and hospitalists, and that's possibly why they're hard to come by. There's a shortage of those folks because that's a real job dissatisfier. And there's definitely room for improvement there. I mean, some other areas of improvement could be improving efficiencies with better point of care data. So you can order a medicine and know at the time you're ordering it whether or not it's actually covered by the patient's insurance. So that's such an inefficient system now where you order it, the patient's got to actually go try to fill it before someone can tell them if it was covered or not. And the same is true with various testing, CAT scans, MRIs, and whatnot. If the diagnosis doesn't fit with the symptom rather, with the test you're ordering to the whatever the insurer's satisfaction is, you're better off knowing that right up front, that rather than either the patient, 2 days later going there and getting turned away, or getting a bill for the entire cash cost of the, whatever your hospital's charging for that service, or just not getting it, or some other primary care provider or orthopedist or whatever who's not the ordering provider, but he's covering, and it's a Thursday night, and they're like, I don't know, if you knew right when you were ordering it, it could just make things just that much more efficient.
Kathy, I'd like to add just a little bit on that too. When you talk about, we want to, a lot of the data in the previous years has been kind of post. Things have happened and we look at it and we say retrospectively what happened. We really need to shift more towards more prospective and actionable information, more kind of like as we were talking about with work queues in your primary care office, that okay, this week I've got this many visits coming up, and in here, the primary care doc knows 5 of the kids he's going to see haven't had their vaccines. So they kind of know their work queue when the patient comes in the door, so that it makes it easier. It's a seamless transaction for both the patient, the physician, and everybody, knows what's on the table, if you will.
And that's a great point. And actually, we have a project going right now in the outpatient realm for primarily the PCPs, where there's a program that we've created that does automated chart prep to do that exact thing.
Yep.
So it unburdens the providers in a meaningful way that is to the benefit of ultimately the patient.
Everybody, right.
And it gets rid of some of that sort of the tedium that drives everyone just crazy. And it's a way to leverage the information that we already have, just find an elegant solution to dealing with it. Absolutely.
And I think that probably provided a great segue to our next question, which is what's next in terms of your use of analytics? And David, I'll start with you here.
First, I think going forward, this will be one of the key differentiators, between organizations and providers in terms of how we deliver care. And I think what we'll want to be doing is considering more factors and using tools like artificial intelligence to help make the best decision for an individual patient. Now, the way that artificial intelligence works is it takes a look at all the data that you have available about, say, an individual, and then can use that to come up with a best recommendation, for them as a person. So for example, it might help you pick which drug is the best drug when you're starting somebody on a medication for that individual, or for somebody who's in the hospital, what safety risks or is that person exposed to now, and which things are things that we should really be worrying about, and which things are things that we don't need to worry about so much. We've done some other work on figuring out, for an individual, how could costs best be reduced, or which cancer treatment is the very best for them, both given what you know about them and their genetic information, but also the genetics of the tumor. And more broadly, I expect that we will start personalizing therapies for patients at a level that we haven't been able to, and that might include recommending for one person that they exercise more, that they change their diet, but it also might involve a different treatment.
And Frank, what's next for your organization?
Well, for us, we're in a unique position. We just completed a merger into the UMass Health system as of July 1st, and that's the end result of a multiple years long journey exploring it and creating an agreement. And in the months prior to the merger, we've had transitional meetings, and maybe there's some UMass folks out on this call, but the rest of the system a few years ago underwent a kind of a big bang conversion over to Epic, for their EHR, which, its usage is global across the system. We're not an Epic shop here. We have Meditech in-house and Allscripts in the outpatient world. So we are now, and we've already been talking about it for months and months, but in the process of planning to convert over to that platform like the rest of the system. And of course, along the way, as we integrate with the rest of the system, we're starting to try to look at things in the same way, like this. And there's obviously a lot of overlap in the metrics we're already following, but they weren't identical, or there's different emphasis. So we're aligning all of those things, but our data sources are different than theirs, and it's not entirely clear if the methodologies used to create the metrics are identical because of different programs. So we're bringing all that into line and learning a lot in the process. I mean, as I said, I have a master's degree in biomedical engineering, but I look at some of the equations that CMS comes up with for instance, the excess readmissions, and it's a page-long equation. It's incomprehensible. There's nothing intuitive about it. You look at it and you go, well, I guess we're going to try to reduce readmissions, but you can't really glean anything from the equation itself. But I mean, we're trying to develop a better understanding of that and be able to compare with some confidence, hopefully apples to apples, and not just looking at our data and going, geez, like ours doesn't match theirs, but we don't know if it was created in the same way. So how do we really compare them? And that's the same across multiple other systems and looking at, across the region, et cetera. But that's really some of the stuff that we're looking forward to grappling with, in addition to putting some more emphasis on health equity issues, other population health management, social determinants of health. We have this awesome new Anchor Mission program that's a charitable sort of an investment into the community that the UMass system was already doing, but that was I think first time in the nation where a merger deal included that as part of the definitive agreement. We're just getting started with that, and we have great optimism that that's going to reap dividends down the road. But I think it'll take 2 or 3 years to really see the beginning of that.
And Nora, what do you think is next in analytics?
Again, I still think it stays in the same lines. We've got to go more towards operational and actually actionable data. To give an example of what Frank was talking about, trying to get everybody on the same platform. When I was a customer working at the hospital in the South Florida hospital, it was this, at the time we were a 7-hospital system, and they were trying to coordinate CHF care. It was all the same doctors, it was all the same process, the same hospital system, but if they went from hospital A to hospital B, they kind of chose a different med because they felt like they could, so we had a committee that actually met for over a year, trying to coordinate and find, get a common ground, to the point that they actually, the committee wound up getting $1,000 bonus. Everybody got a bonus because of what they accomplished in lowering their cost and getting more things online. And I think that's the way that as organizations continue to expand and they want to try and consolidate, then that's where you're going to need to look, is how can we coordinate amongst ourselves to improve. And I think that that's where you're going to see a lot of that, is really getting actionable data, and how can we improve our processes and what we're doing now.
Thank you. And just a reminder to our audience, please put any questions that you might have into the chat box. We will get to as many questions as we can. I know that I wrote down a lot of follow-up questions, so if you don't have any, I do. Let's start off by asking, and any of the panelists can feel free to chime in for any of these questions. What advice would you have for C-suite leaders who maybe haven't fully waded into analytics yet? Maybe they're just trying to wrap their heads around how they can start to use their data.
Well, maybe I'll start off there. I think that this is a key thing for C-suite executives to understand. And there's a few key pieces of infrastructure. You want a central data repository so you can look at all your data. You probably, most places will want some data scientists. You have to decide how many. That's something that we haven't necessarily thought about. You got to decide, how much of the team is going to be inside versus outside. With analytics, there are choices about whether you want to do a lot of it yourself versus purchase it from somebody else. I think most organizations are going to want to do some purchasing, and there you got to sort out, do you want to go and try and get most of what you want from one entity? Do you want to have a couple of different organizations that you work with? And how do you keep that under control so that you don't have too many different solutions that people are trying to use? So this is a really important area for C-suite executives to learn about today.
Frank, Nora, would either of you like to chime in?
Sure, I would agree with, I'm sorry. Go ahead, Frank.
Oh, go ahead.
Okay, I was going to agree with David in the fact that, one thing that's critical too, I think, from the C-suite piece of it is in looking at the offers coming forward or the suggestions, there is no one answer for how to get your analytics. There might be several tools that have better visualization, but something else might be better this. It's really taking a look at the whole picture and understanding that, look under the covers, understand the process that you're going through. And I would also recommend that it be highly interdisciplinary, that everybody understands is in the same game. I can't say how many times I've gotten started to do a project with a customer, and I get contact with the IT person. They go, well, I don't know what we're doing. We just got to give you that. It's really getting the entire organization engaged. Oftentimes I find our roadblocks is when maybe the CFO or the CMO or one of the seniors bought the product. They love it. They love what they see, but the information never got down to the people that are going to implement it as to what the goal is and why we're doing it. So I think that that's a critical piece in the whole process as well.
I agree. And I would say that, first of all, if anyone's not using analytics, and I'd be shocked, I think everyone's got it to some degree. But I mean, if not, hey, wake up and smell the coffee. There's just no way to avoid this. The key is just being able to figure out how to use the analytics and the data, intelligently and efficiently. I think you have to be disciplined enough to come up with a plan that's manageable, with measurable results along the way, and have your whole team on board with it. And I think there are projects that could be viewed as more quality and clinical based, and those that are more kind of businessy, based and not really directly related to patient outcomes. And of course, the gems are the ones that encompass both, where it's a win-win. People are doing better, and you're shoring up your business. I could, as an example, for us, a couple of years ago, we started really, for the first time, really taking a close look at what we were doing for colorectal cancer screening, like how we were performing. And we had quite frankly, pretty poor screening rate. And we started measuring it, and we had to come up with a plan to how to react to the data that we had. One of the things, aside from just cajoling providers, was to develop a system where there was going to be automated reports for who was due for it and in need of it and receptive to it, and increasing interactions with patients via clinical navigator. And over a 2-year time span, we increased our cancer screening rates by 60%, from well below the state average up to just slightly above the state average for screening levels. And that is, of course, it's a huge win, because that's a great patient quality story. You're saving lives. And from a business standpoint, you're creating revenue, because all of those people need colonoscopies, and you're getting that done. Shoring up your own workforce and creating satisfaction for everyone involved in the process.
One key thing that Frank said that just drew me was making sure it's in line with the strategic plan. Because one of the experience that I've had is, once you start getting data, everyone's like, can we do this? Can we do that? And it gets really wild. So it's like, okay, yes, this tool can do everything you want it to, but let's get it in line and let's have a plan and follow our strategic plan, as opposed to just going, hey, that's really cool, let's try this. And because then that kind of happens a lot too, where it's like they get too many can we's and you don't finish any.
Sure. And I would add too that, whatever you decide upon, it's likely to be some combination of, one way to look at it is there's proactive endeavors, like the colon cancer screening thing, but then there's reactive,
Yep.
You're getting a bad report card from CMS, or you notice that, Worcester Telegram and Gazette's comparing you to other hospitals in your region unfavorably. You say, well, how can we fix that?
Right.
Inevitably, you're going to come up with a mix of those, and that's just natural, I think.
And Frank, you had talked about finding the meaningful metrics. And I'm just curious as to, have you found that there are any particular metrics that are most useful to measure for your organization?
And I guess certainly that's a very subjective term, to be honest, because what might be important to one person might be kind of less important to someone else. And I guess that's the trick too, is getting everyone aligned in terms of the objectives. As a clinician, I have placed a lot of emphasis on the clinical quality type metrics, but in my more administrative role these days, and just dealing with the workforce as a whole, it's very important to be measuring, how people are doing in terms of, are they being overwhelmed because we're very short-staffed, or have we overdone it and we've overhired and now people are standing around with their hands in their pockets and it's bleeding limited resources out of the system that could be better utilized somewhere else. And of course, it's all quite dynamic, and there are a lot of things that are just simply not predictable, but you just do the best you can with the data you have.
And what I would say about that too is that it's a moving target, and you might be doing really well on something for a while, and then all of a sudden things slip off, and you've got to pick things up. So the ones that are most meaningful are whichever ones you're not doing well on at the moment.
Now, I call it my pain point. What's the hospital's pain point? And I can go to 3 different hospitals with the same exact tool, and they're asking for the same thing, but each one of them has a very different approach at it, because that's their pain point and how they need to handle that pain point. And you may have, you're just going to find different places depending on the organization and even where they're located. What's more important, if you're located in a resort area, you're going to have different types of needs than somewhere else in the older population. So it's very different.
Yeah, and I think part of it too is dictated by the size of your organization. And, a lot of things are important, but some things are easier to get at because they involve, like every single patient or every single child, but then there are other parameters that are just inherently so infrequent that they're hard to wrap your head around. And you know, you can only devote so many resources when things are limited. And I can use an example of, you know, we're a pretty small place here. And if you look at the PSI, Patient Safety Index at 90, it's a composite of patient safety indicators, and they're weighted due to severity. So if you have one misstep in a small organization, it's going to impact your score for months. It'll sink you for a whole year if you have, you know, one patient fall and break their hip or something. And so, of course, you want initiatives to prevent that, but it's so much harder to be dealing with something every day, every person, when it might only happen once every 2 years versus every single patient who's coming in the door, we're going to recommend them a flu shot or whatever. I mean, those are, and again, that's prioritization. There are limits to what each organization can do, and you just have to decide what you're going to make your top priorities until you have it dialed in so that you don't really need to think about it.
Now, Nora, earlier you talked about the customer that you have in Puerto Rico, the CEO who has his analytics on his iPhone, and every morning, you know, that's the first thing that he checks. And it seems that that is a great way to ensure that people in the organization are actually using their data to make better decisions. So I'm wondering, are there other ways that we can help increase analytics usage in the C-suite?
Well, my experience has always been the engagement has to be at the top, the stakeholder. You know, I worked for an organization before, and I brought our product in as a customer at that point. And the only way I was successful, because the mantra of the CEO was, if you're not using this tool, then you're not doing your job. Because it was her, so I really feel that the C-suite has to set that expectation that you will look at your data, you'll understand it. And her expectation was she can walk down the hall and ask the OB director, how are our volumes looking this month? And that person would know and almost be able to quote a number to them. And so it really is having that, whether it be the CEO or whether it be, you know, if radiology brings in the thing, then the director, somebody, they have to have a leader that believes in it and uses it and actually helps to reinforce the use of it. Because if they don't, then it's just, it kind of sits in one area and doesn't, others don't benefit from the tools that you have in hand.
Great. Now, we just had a question that came in, and it's around, do you have suggestions as to how you keep each department and leadership focused on that larger strategic plan, as opposed to just responding to the loudest voice?
That's a great question. I think part of that is involving those key folks in the decision-making process to begin with. That helps people get behind it. Keeping people informed, and again, creating a tangible way to monitor the plan and to modify it as need be. I think it's certainly, if you come up with a plan, then it's never going to be a set it and forget it, not initially. And if there's no discipline to follow it through and keep an eye on it and keep people sort of engaged and responsible for the results, then people will lose focus. But again, you also just have to be able to achieve that initial buy-in.
Right. Kathy, I will take, like, again, that original organization that I worked at too, similarly, it was, you have to really, in order to bring in all the operational people, they all have their own operation of business, if you will. Radiology has theirs, ER has theirs. So giving them information to help them run their own operation that actually rolls up to the overall operation helps them remain engaged. And one example is when we started implementing the tool, you know, finance puts out a budget and they give you, and this is your budget, this is your FTEs, this is your stats. But their numbers are often quite different than what the operational people use to staff. For instance, you know, they might only count in the ED, just billable ED visits, but the ED also sees returns and they see people. So it's really getting the organization to agree upon, you know, what are the metrics that we're going to be measuring that I can believe in, so that you're going to hold me accountable. I have to believe that that's a metric I can meet or even not meet. Or so you, to your point, you work it together. It has to be multidisciplinary, that everybody agrees upon it so that it becomes not just the CFO's goal, but it's the organization's goal. And I'm a part of that and I win from that.
And I guess I would say that you really do have to have some component of this that is self-service so that people can ask the questions that, you know, that are meaningful to them. And along the lines of the example that Nora just gave, you know, if they can't take the people out that they think are, you know, not important, they may just not pay any attention to the data. So that self-service part of things is just really pretty critical.
Yeah.
I would add too that communication is just vitally important. And it's way better to over communicate a lot of these things. We have the advantage here in our subset of the UMass world at Harrington of probably about 90% of our providers are in our area are employed by us. So we have a bit of a captive audience there. But in addition to, you know, as the question alluded to, the department chiefs who meet regularly, we also have a physician advisory council, which includes, there's some overlap between the groups, but there's certainly leaders within the system who are leaders in action, but maybe not in title. And it's important to get those individuals in the loop and engaged, and of course that get their feedback on a lot of these things, and then just keep them informed of the processes, both in the results and the plans to modify based on how we did before and what the plan going forward is. You know, and of course we meet with managers regularly, and it never really, you know, looking at the COVID pandemic again, like we were having just meetings, you know, multiple times daily and seemingly, you know, nonstop sharing of information. But it always surprised me. There's always some corner of the world that you can't get to, and you meet someone in the hallway and they're like, hey, what's going on with, you know, I heard there's a virus out there, and you're like, how do you not know? So it's just hard to over communicate, I think.
Now, earlier we had talked about discrepancies in data. Frank, I know that you mentioned some discrepancies from different organizations in some of the reporting to the state, but there's also internal discrepancies between departments in the data. So what are some best practices in terms of resolving those discrepancies and making sure that people are looking at a specific data point the same way across departments?
Yeah, I mean, I guess to get down to the integrity of the data, it's just going to basically require the knowledge on a super granular level of what you're actually entering, and hopefully it's consistent. Like I said, I've seen it, and you can see it on the having participated in, you know, multiple calls through DPH and MHA. And all of those spreadsheets they're sharing, you could tell the data from the same organization reported by two different people was often grossly different. And there's just so much of it, you know, it can be a real challenge, but you have to have enough knowledge of it to be to, at least on a very basic level, look at it and say, well, at least this directionally makes sense, you know, and what are we going to do with the data? You know, how important is it to get it perfect versus, you know, well, we're off by one bed, but same difference, you know, that kind of thing. And depending on what you're doing, it will matter sometimes more than others. But again, it's just, I think there's a tedium there that just requires someone's really close knowledge of what's going on there. And that's, you know, of course, above and beyond just two different systems, calculating, using different methodologies, that's a whole different thing. For someone like me, I'm I'm not in there writing code. I'll have to trust the data that comes out of Crimson. And I'm not looking at the equations, and it's a black box, but you have to, someone's got to know how it looks, you know, and that's why, you know, Dr. Bates mentioned you need those analytic folks on the team who have the ability to make those assessments.
I would agree too. You know, sometimes even in the same EMR, depending in the same field you think you're looking for, depending on which table you take it from, you can get a different answer. So it's really having people understanding not only from the outside, but also the back end, which is why I think you've seen a bigger paradigm shift where people in IT are actually, you know, you're seeing a lot of clinical folks now getting into the IT realm because they understand that, you know, IT understands they have to understand the business to be able to produce for their end users oftentimes, and they don't know the business. So now they're widening their net on employees to bring in so that, you know, they're of the mindset that if you come in with the knowledge of the clinical piece, I could teach you how to write the code, but I can't teach you the clinical piece if you write sometimes when they're writing code. So it's really having that paradigm shift of clinical folks getting into the IT world and helping to beef up the knowledge base at that end, I think.
Yeah, I think it's key to just know what the potential pitfalls are. You know, it's like the parable with the 3 blind men and the elephant. You know, it's hard to know what you don't know, and if you just, you know, putting your hand on the elephant's tusk, you think they're all bone, and otherwise, if you're touching their tusk, you think it's a snake. And everyone's, you might consider themselves an expert if they don't step back or take the blindfold off.
Right.
I mean, one real world example is, which is the bane of many physicians' existence, is medication reconciliation. If you've got take 3 different docs medication list for the same patient, and they're on more than one med, there's going to be it's near certainty they won't agree, and then you have to decide what is the what's the jargon, the ultimate source of truth. Right, Dr. Bates? It's that's the trick, and it can be a real challenge.
Well, we only have a couple minutes left, so I have one final question, which is about artificial intelligence. We've heard a lot about AI, and you know, during today's discussion, we talked a little bit about some predictive capabilities and, you know, being able to look out a few weeks and understand what census may look like, or what, you know, vaccine demand might be. So I'm curious just as to, you know, when we think about AI, a lot of it seems to be a lot of hype, but what are the most successful applications right now? Or what might some of the most successful applications be in the next couple of years?
The most successful applications so far are largely in radiology, and AI has been shown to be very good at predicting things like is this mammogram normal or not, and it can do that, for example, with a very high degree of accuracy. And the advantage is that the radiologist can just focus on the small number of mammograms that have questionable lesions, and the vast majority can just be written off as normal. And then they can spend time focusing on those ones and thinking about it. Is this a real thing or not? Similarly, for reading of retinal images, it's really good. For reading of many types of very stereotyped images, it's really spectacular. It's going to be very good too for digital pathology, but we'll start to see it used in many other clinical areas, more broadly, and also for operational things, as Nora was describing, can just help us make better business decisions. One of the key things is with AI, you typically can't explain exactly how the algorithm got to its answer, and physicians and nurses are used to wanting to ask, so how did you get to this answer? And when you can't explain that, it's a little tricky. There's some ways to help out with that, but I think one of the hard things will be just for frontline providers to buy into the likelihood that the predictions that the AI is making are correct.
certainly not my field of expertise, but agreeing with Dr. Bates, I think that when there's things that are much more objective, that's AI is going to be applicable or algorithmically driven. When you introduce patient preferences and opinions into it, which is part of the human side of medicine, it becomes more difficult. But take off small bits, and certainly there's a room for improvement in consistency of therapies. I think we've made great strides in that already without the help of AI, but through data sharing, where I think there's much less, say, regional differences across our country in how various diseases are treated, where that was probably not the case if you go back a few decades.
Nora, any
Right.
final
Well,
thoughts?
No, just again, I ditto what both Frank and David have said, and really in the AI world, it's more, I see it as, it's going to be a paradigm shift for clinicians to understand that AI is not meant to replace your thought process and your clinical decision making. It's really meant to enhance your ability to make that decision, maybe perhaps quicker and more focused, as opposed to where I think some pushback is, well, no one's going to tell me how to practice. Well, it's not really telling you how to practice. It's giving you ideas. Like I heard of a great example of, and I might get this wrong, but at the VA where they had, I forget the name of it now, where the name escapes me, where Isabel, and where, where someone else was talking about another time where they had, it's an AI tool that when you began to plug in the human factors of how people subjectively said how they felt, and then some of the things that this AI algorithm would spit back, these are the top 5 diagnoses you could be dealing with, but it also gives you about another 25 differential ones that you might not have even have thought of, because, the example was this person was at a concert in Pennsylvania. He lives in a state where there's really not a lot of deer ticks. So when he was discussing it and then you put it all together, all of a sudden Lyme disease came up, and you might not even have thought about Lyme disease because it's not in your forefront. That's where I see the value of AI is kind of giving me, it's the work cue. It's giving me the help to kind of spur my brain and say, there might be a couple other things you might want to look at. Because, sometimes it's that aberration that you don't even think of. All of a sudden it's like, wow, if I had only asked this one more question. So I think that's where it would be helpful too.
Great. Well, thank you to all of our panelists and to all of our attendees for joining us today. Please check out the MHA website for more information on upcoming virtual events and webinars. We will be sending out an evaluation which will ask about what additional topics you would like to hear more about. Thank you again.
Thank you, everyone.
Thank you.
Have a good afternoon.
Thank you. Bye-bye.